And on Good Morning Nigeria today, we focus on the country's response to current Ebola threat.
Nigeria is stepping up its health security playbook as Ebola cases raise fresh concerns across parts of Africa.
And President Bola Tinubu unveiled a major response package, approving a presidential task force on Ebola preparedness and releasing an immediate 10 billion naira emergency fund to reinforce the nation's frontline defenses.
And this is all about staying ahead of the curve. From airports to border corridors, health authorities are being placed on heightened alert.
Now, the funding will strengthen the Nigeria Center for Disease Control and Prevention, while, of course, a special task force chaired by Chief of Staff Femi Gbajabiamila coordinates a nationwide strategy to detect, prevent, and respond swiftly to any potential threat.
It's a race against risk, and Nigeria is choosing preparation over panic. Enhanced passenger screening, isolation facilities, tighter surveillance, and coordinated action across federal and state institutions are now at the heart of the government's response.
So Nigeria's response to the Ebola outbreak in the DRC is our first conversation on Good Morning Nigeria today. We'll also pay some attention to the 2026 FIFA World Cup, which kicks off today. Thank you very much for joining us. I'm Victor Azu.
I also join my colleague Victor to welcome you to Good Morning Nigeria. I am Ademola Adeoye. Thanks for staying with us. You're still on to Good Morning Nigeria on the network service of the NTA. Before we commence the discussion and the Nigeria's response to the Ebola outbreak, which is our focus today, we'd like to join our correspondent, Joel Pukwola, at the Murtala Mohammed International Airport in Lagos to tell us and give us an update about the returnees, the evacuated Nigerians from South Africa. Joel, tell us, what is the situation at the airport right now?
Thank you, Ademola. I'm here at the Murtala Mohammed International Airport. And like a pregnant woman in the delivery room, we are here awaiting the returnees. I learned about 262 of them are airbound at the moment, and we're expecting them. Initially, we were expecting them by 5 in the morning, but the flight was rescheduled to 9 in the morning, and later now we are expecting them by 11 in the morning. And we are hoping they will arrive safely after enduring the relentless attacks, physical and psychological attacks in South Africa. At the moment, we are expecting them by 11 o'clock, 262 of them. Initially, we had that about 268 returnees are coming, but 6 of them, I was told, by the officials of the ministry, stayed back in South Africa. And the Minister of State for Foreign Affairs, Ambassador Shola Enikan Olaye, is expected to receive them upon arrival, and they are expected to be accompanied by the Nigerian Acting High Commissioner of Nigeria to South Africa in Pretoria. Acting High Commissioner of Nigeria in Pretoria is expected to accompany them, and that is Alexander Ajayi. At the moment, the waiting game continues, but we are hoping by 11 they will be here at the Murtala Mohammed International Airport in Lagos, and journalists are on standby. We are all on standby, awaiting their safe arrival.
Thank you very much. But is this a one-off operation, or is just the first batch?
The first batch, it is not a one-off operation. Some Nigerians who are stranded in South Africa are still registering, indicating their interest to return home in the wake of the xenophobic attacks in South Africa. So this is just the first batch. Definitely after this first batch, the arrival of the first batch, subsequently more Nigerians who are in South Africa who are willing to return to the country will be airlifted down to Nigeria.
Joa Popola for that update. We'll return to you much later when you have more news to give on to us concerning the returnees. Thank you very much. Now, you're still watching Good Morning Nigeria on the network service of the NTA. Today, we're talking about Nigeria's response to the Ebola outbreak, which is our focus today. Just before we bring in our guest on this program, let's listen to Oyeyemi Ajayi for this background report.
As at May 2026, the federal government of Nigeria identified 21 states and the Federal Capital Territory as areas of high or moderate risk of Ebola importation following renewed outbreaks in parts of Africa. The Nigerian Center for Disease Control and Prevention, NCDC, disclosed these after placing states across the country on heightened Ebola preparedness alert amidst fears of cross-border transmission. As part of the emergency measures, the President directed all states hosting international airports and major border corridors to submit detailed preparedness plan, funding requirements, and intervention needs for coordinated implementation by the federal government. The task force is also expected to immediately intensify passenger screening at international airports through enhanced temperature checks and stricter crowd control measures. Also, authorities have been directed to strengthen monitoring of travelers arriving through identified high-risk routes, including flights operated by Air Uganda, Rwanda Air, Air Tanzania, Air Angola, Kenya Airways, and Ethiopian Airlines. The epicenter of the virus is in northeastern DRC, with confirmed cases also reported in and around Kampala, Uganda. Death toll in DR Congo has been reported to have climbed 101, while Ugandan cases have surpassed 600. On his part, the Nigerian President, Bola Tinubu, has approved the establishment of a presidential task force on Ebola virus disease preparedness and emerging public health threats, and authorized the immediate release of 10 billion naira to strengthen Nigeria's emergency response capacity against the deadly virus. Worthy of note is that Nigeria hasn't recorded any case so far. The emergency funding is expected to bolster the operational readiness of the NCDC and support critical public health response activities nationwide. The newly constituted presidential task force will be chaired by the President's Chief of Staff, Femi Gbajabiamila. Relevant ministries, departments, and agencies are to submit their plans, funding requirements, and intervention needs for consideration and coordinated implementation. Now, with this, has Nigeria created a formidable buffer and protective structure against the virus? What is the government doing differently when compared to the previous case? Our guests already in the studio will be answering these questions and more shortly.
All right, many thanks, Oyeyemi Ajayi, for that background report. And now to get our guests having this conversation on Nigeria's preparedness, let me welcome here in the studio Dr. Fatima Saleh, who is the Director of Surveillance and lead Emerging Viral Hemorrhagic Diseases Technical Working Group at the Nigeria Center for Disease Control, NCDC. A pleasure to have you join us on Good Morning Nigeria.
Thank you for having me.
All right, we have also been joined here in the studio by Professor Abdulsalami Nasidi. He's a professor of virology and public health. We thank you very much for joining us. And the former head of the NCDC himself.
Yes.
Thank you very much, Prof.
Thank you very much. Thank you.
Also joining us here is Benga Joseph. He's the Deputy Director and Head of Department Health Emergency Preparedness and Response. Benga, it's good to have you.
Thank you for having me.
All right, good morning. Now let's start our conversation with Dr. Saleh. Dr. Saleh, tell us, what is the current Ebola risk and for Nigeria right now, and how does it compare to what we had in 2014?
So thank you once again for having me. The Ebola disease, as you rightly said, is something that has happened before now. We had experience in 2014. Our former bosses here where we really contained the outbreak. So currently we had activated what we call the technical working group for the emerging viral diseases, which Ebola is one of such, the Marburg, the dengue, And the assessment that we did as a country through that technical coordination is that we are currently on the alert mode. The alert mode connotes we remain watchful. Yes, we don't have a case yet, but high vigilance is the watchword here, so that we remain prepared in case of any importation.
How high is the vigilance? As high as 2014 or catching up?
Yeah, so because that 2014 had provided us with learnings. And that learnings has informed even our preparedness. From that 2014, you could see how we had expanded even in our laboratory networks, how we had established isolation and treatment centers, how we had expanded in our training and having a very robust, skilled, rapid response teams to be deployed anytime to swing into action, how we had also heightened our surveillance at the points of entry, airports and the borders. As we speak currently, you could attest to it that passengers coming from especially those countries of interest are really being screened at the airports and other points of entries. So it's a way to ensure these passengers coming, we call them passengers of interest, are tracked in the event they develop symptoms. We pick them and activate all protocols, the contact tracing protocol, the care for these passengers of interest protocol. We have a toolkit, a very structured, and objective way of assessing this through phone calls, across the various states.
All right, thank you. Let me get to Professor Nasidi. Now, Prof, even from 2014, which you might have played a part in, Ebola remains a feared, infectious disease. What makes it particularly dangerous from a virological point of view?
Well, once again, thank you for having me. The main issue is, unfortunately, infections, that are bordering humanity now. More than 60% of them are caused by these viruses. So the group of viruses that are now, giving us headache, like the Lassa virus, the COVID virus, the flu viruses, and then the Ebola virus, happen to be spreading, uncontrollable. And some of them have cures, some of them don't have, some have prevention, some don't have. Unfortunately, the Ebola virus belongs to those group of viruses. They can take us by surprise. They are mostly, circulating within the nature, and when they affect any human from their reservoir, and they can bring it to human habitations, either in the rural area or in the urban area. So what makes Ebola a little bit more worrying is that it is a single, stranded RNA virus. That means the genes, so it can replicate very quick, and it causes a lot of. The death rate from those who are infected is very high. So in most of the outbreaks, it exceeds 40–50%. So a disease that kills every other second person definitely is very worrying. Then secondly, a disease that up till now, they are still finding more reservoirs. We don't know fully which are the animals that could, transmit this. And then the last one, just like Lassa, is it creates a lot of what we call nosocomial transmission. That is transmission inside healthcare facilities. When it comes to the hospitals, all this, it quickly spreads among healthcare workers and start killing healthcare workers. So this is why it's being feared, and it could also be used for biological weapons and this, and so that's why we don't want to joke with them.
So is that, Prof, is that a strain of the that is circulating currently now? And you just talked about the transmissibility of it. How severe is it?
Well, just like you might have been reading, this is that the one that we knew that was causing more of the outbreaks is the Zaire strain. There are about 6 strains, but 4 are the ones that are known to cause the human infections so far. And the first one is the Zaire strain, the one they found in the early 70s in the Congo Democratic Republic, and then the Sudan strain, which also was found concurrently in Sudan. Then you have this Bundibugyo, which is the strain that is causing the current outbreak. But the most important thing is that the Zaire strain is one that has caused more frequent outbreaks, and so concentration was made on how to handle it, to develop vaccine against it, to develop therapies and treatment against it. And so the current strain, the Bundibugyo strain that is causing this outbreak, has caused only 2 small outbreaks in the past. Okay. So we thought they are not very consequential. So all the scientific research and development efforts were concentrated on the Sudan and Zaire that are causing more than 80% of the outbreaks. Okay. But this current one, nobody knew that this strain can cause such a big outbreak and spread so fast. It was known to cause small cases and not to spread so fast. So now that it's spreading so fast, with even intensive or with severity, leading to, again, high case fatality rate, is making the world to bother. That it means it is adapting more to human cells. So if the viruses start adapting more to human cells, they'll be able to infect you easily, and they'll be able to cause death easily.
Wow. All right. Let's bring in Mr. Gbenga Joseph now, who is the Deputy Director and Head of Department Health Emergency Preparedness and Response, to tell us the preparedness and the response that we have. What does activation of Emergency Operation Center actually mean, at this moment? And who is in the room, and what decisions are being made right now?
Okay, thank you again for having me. When we talk about the emergency operation centers, because we have many stakeholders that are involved in the response, there is a need for us to be able to have a unified coordinations so that we can ensure that resources are properly managed, and then we ensure that the response is effective to be able to achieve the set objectives. So the Emergency Operations Center is a system that brings all stakeholders together to have a unified and a coordinated response approach to be able to respond to any potential outbreaks. And we have what we call incident structures, incident management structures. In that structures, what we do is that we have different pillars, and those pillars are well coordinated so that they can respond based on terms and objectives set for each pillars. And one of the advantages of having incident management systems in a coordinated approach is for us to be able to ensure that different stakeholders of different mandates come together, like Ministry of Agri, Ministry of Health, different MDAs come together under one system, having a coordinated incident, having an incident managers that coordinate all the system to be able to respond to any potential outbreaks. Currently, what we have is to place our incident management systems on the alert mode. And what that means is that there will be enhanced surveillance, and then we also strengthen our capacities and capability to be able to test, detect, and respond as early as possible. And at that point, we also enhance our preparedness mechanisms and ensure that all the readiness measures that we need to put in place, in case we have a case now, what do we need to do? Can we respond immediately? So that structure is put in place to be able to have a coordinated system among different sectors to manage the resources available, both the woman resources, and then the financial resources to be able to respond effectively to any potential outbreaks. And it has been one of the global strategies that we use to coordinate such emergencies so that we can respond as
Do you have
early
all
as
these centers in the 36 states of the Federation, including the FCT, and you have isolation wards as well?
So one good thing about the Public Health Emergency Operations Center or Incident Command Systems that we have is that at the national, we have what we call the National Public Health Emergency Operations Centers. And we also have them at the state levels. And at the state levels, they also speak to what we have at the nationals. There is a guidance, there is a guidelines and protocols that connect all the federals and the national. So we have the PHC at the national levels, we also have it at the state levels, and we also have a mini command system at the local government. And that structure speaks to each other's. And one of the good things about the structure is that there is a mechanism, there is a standard, there is a protocol in place that guide every operations. Because in every emergency, one of the things that you must ensure that you do is to have a one line of commands, unified command, one plan, one command, and one MIE, so that you can respond as effective as it may be. And that system has been put in place. So currently, every state is on alert mode. That means they need to enhance their preparedness measures and be ready to be able to respond to pick any case as
I
early
like
as
the
possible.
confidence with which you speak about preparedness, Dr. Benga. But if there be a case now, how many minutes, how long will it take to deploy a response team?
You can deploy the response team within 24 hours.
24 hours?
Within 24 hours. So that is the language we use within 24 hours. But with the system we have put in place now, since we are on alert mode, we can deploy a response team within 1 hour. What I say within 1 hour is this. We have the response teams that have been trained at the national level who can respond immediately within the state around the FCTs within that 1 hour. But we also have the response team that has also been trained and they are also alert at the state level and they can also support the response at the state level. But you know, nobody can claim an absolute readiness. We are trying to see what we can do and ensure that we respond as early as possible. They have been trained before. Effort is being put in place to ensure that they are also retrained so that they can be effective and then be familiar to the correct.
All right, thank you. Thank you, Dr. Benga. Dr. Sali, I'm wondering, how does Nigeria's surveillance system detect a suspected Ebola case before it spreads?
Yeah, so as I've mentioned, the previous Ebola COVID-19, we still see has provided us with opportunity to learn and has made us establish structures that we are sustaining up till now. I'll give you an example. Way back, historically, you see that we've been dependent on paper, manual surveillance platforms. But as we speak today, again, thanks to COVID, because it has given that opportunity to, leverage to, do the needful in terms of real-time surveillance, platforms that you could get real-time information that could inform, prompt, of course, intervention and response. So we've gone beyond the paper. We've gone digital, using what we call the SORMAS. It's an acronym for the surveillance platform that we use. There's a surveillance outbreak response management and analysis system. That's the software we use, such that when diseases such as Ebola are detected, these are notified real time. We plug in and we get the information across level up to the national so that we swing into action. So again, we also had expanded into what we call the early warning systems for surveillance activities. We have the event-based surveillance, where, I give an example, a few days ago, that platform had detected, is a social media platform where you scan, you track what's happening around public health. and you get this information and, verify, and you plug into the usual surveillance information flow. So we got that suspected case of Ebola via that platform. We did the needful quietly, activated the follow-ups and the close monitoring of that suspect with our usual standard operating procedure. Did the testing, and it came out negative, and we discarded it. So that is what, real-time surveillance does. So the event-based surveillance is really one of our early warning, because it peaks even before anything. And also the community-based surveillance, because we know that outbreaks, public health events begins and ends within the communities. So we had established what we call the community-based surveillance system, which before we are not really very so forthcoming on that. But this is been established, it's been implemented. We have strategies for doing that. We have roadmap for doing that. We've started that across states. This is all geared towards ensuring that the surveillance system is beyond the usual indicator-based surveillance where it's passive, information just flow. Now we actively do that, including leveraging technology. That's the.
So what you're saying now, Dr. Saleh, is that you've been able to, the government has been able to scale up, surveillance, especially at the airports. What about the land borders and, the seaports? Have you been able to scale up surveillance in those areas? And what are we catching? What are we missing? What are the missing gaps in all this?
Yeah, so I like the idea of the land borders, because, some of these land borders are not really manned. They are not designated. But what we do, we acknowledge these are really, really potential risks for us as a country.
Yeah.
So as we speak, we are not yet everywhere, but we will leverage those states where those borders are. And we have what we call the land crossing officers, that's the portal services, with the officers manning those places. We have a platform where digitally such information, are submitted to us at the national, and we, utilize that information and do the needful, because it's part of the national surveillance system. So you could also recall that some days back, there was this protocol that was sent by the Federal Ministry of Health and Social Welfare on the passengers, especially of interest, those coming from those affected countries, where there is a screening protocol, there is a health declaration form. These things are done in such a way that we mitigate and limit the importation of cases. So across land crossing, across airports,
because our land borders are very porous. Yeah. That is where the challenge will be, actually.
Yeah. So again, that's the beauty of that community-based surveillance. Those community-based surveillance focal persons, we call them, they are everywhere within our 774 local and those land borders are within such communities. So those are our agents that pick some of these things, working with the relevant portal services within such localities to really get the information, disseminated to us, and decisions are, taken.
All right. Thank you. Now, Professor Nasidi, given, advances in science since 2014, would you say that we are now better prepared to prevent large-scale, spread of viruses like this?
Well, generally, as she has mentioned, that we've made some progress, no doubt about it. And the progress is mostly on building capacity and at the same time improving on our infrastructure. So what we've been doing and what we did in 2014 was to actually leverage on existing, response mechanisms, not against Ebola or any particular disease. For instance, Nigeria was spending a lot of money, in controlling polio. And so most of the surveillance systems, laboratories she's talking about, were all built around the polio, response something.
And also during the COVID-19 as well.
And so when Ebola came, we established the NCDC, from the Ministry of Health and establish fantastic laboratories all over the country, and started also leveraging on the existing polio labs, polio EOCs, and so on and so forth. So we built on that, and I can assure you that Nigeria's response was so spectacular that then the WHO DG, even declared it a world-class epidemiological detective work that showcased that Nigeria, and it was a wonderful job. So the system we built, in responding to the 2014, Ebola introduction into Nigeria, is now what many countries are using, and the WHO recommended that henceforth, this method we use in responding and should be adopted by many other countries. I can even assure you, even President Obama, hailed our efforts and recommended many countries, including the US, to come and learn from us. So we learned from them, they too come to learn from us. So that was a great job we did. So the next thing is to actually start building our capacity to be self-sufficient, because we can't be doing the same thing all the time. Okay, we've leveraged the polio, then now Ebola system we established, Nigeria is on top, then COVID came, as you rightly said. So it was much easier to now, repurpose all the structures, all the mechanisms that we had on ground, to fight COVID. So it was a little bit even more effective. Then luckily, we had a very active DG at NCDC, Chikwe, Dr. Chikwe, and he now, is a very good public health officer. He now used all those Ebola infrastructures on ground to fight effectively COVID in Nigeria. But as you rightly said, from scientific point of view, have you really moved? Has our ability, to detect early improved? Are we doing any research and development things that will empower us to be self-sufficient, to be, independent of some of the things we need to fight the outbreaks?
And how many labs can confirm Ebola now? And what is the turnaround time?
That one will be answered by Benga. But before I go to that, it's just to say that, if you give me another opportunity, I will talk about the scientific aspect that we should be emphasizing. So now, instead of us to be using the same methods and the routine response and the preparedness, this etc., this is the time has come to start emphasizing, using a scientific approach to build up our response mechanisms, not just to prepare with the drugs that are available. Okay, so yes, if you say, if I go by your question, have we made any progress? We have made huge progress, especially from our universities, from our research institutes. Even the NCDC, reference lab is so sophisticated, and I can assure you, I'm sure by the time my son here will respond, he will let you know how far the NCDC laboratories have gone, being capable to identify the virus. But the issue is, do we have the reagents? Do we prepare the reagents? If we are to buy the reagents, do we have the money to buy the reagents? Do we have, some of the raw materials, pathogen materials that we're going to use to develop our own vaccines? So time has come for us to move from the routine response systems to a little bit more science-based, response system. We are slow on that, but maybe I will be able to expatiate more on what we need to do to even move our capacity and our ability to respond to all these outbreaks higher.
All right, okay, you will have time to do that, within the course of this conversation, I hope, because of time. Now, Mr. Benga, tell us about the number of labs that we have right now and the turnaround time.
So we have our network of laboratories. We have the national reference laboratories, and we have the laboratories at the state level. We also have the capacity to be able to detect. Currently, at the national reference laboratory in Abuja and that of Lagos can detect Ebola. And we also have some other private laboratories that are also part of our networks that also have that capabilities to detect. But one of the good things is that at any point when we have such cases, we need to optimize our process, do some recalibrations and validation of some of the equipment to be able to test these high pathogen organisms. So currently we have a network of laboratories that can test. We have reagents in Abuja that can actually detect Ebola, as we are discussing right now. And we also developed the capability to also do genomic sequencing to be able to identify the strain. And that will guide the response. The prof says that we have many strains. We also have that capability in Nigeria to also detect some of those strains so that can enhance our response and be able to guide us on developing the high impact and highly cost-effective preparedness action to be able to respond effectively.
All right.
Now,
Thank you.
but I still want to ask, because in the last time when we had Ebola, we had many casualties, including health workers, health workers casualty. So what is PPE training and hazard allowance measure are you putting in place for health workers in this instance?
So part of the lesson learned from the 2014 Ebola experience is to be able to strengthen our high-PC infection prevention control to ensure that we protect the frontline health workers. Over the years, we have been able to develop that and be able to train people across states, even develop a curriculum to train at the diploma levels in some of the universities for us to be able to have a pool of individuals who have the skill that can support that at the health facilities. One of the things that we did during this preparedness is to also categorize some of those states and specific port of entries that we can support with the IPC materials so that as they continue to screen the persons of interest coming, they have the appropriate PPE to be able to do that. So currently, we have been able to position the IPC materials and few response commodities to those states that have the internationals in airport and some of the selected states where we think that the risk is high. The effort is still ongoing, and with all the effort that is being put in place, the proactive commitment of the government to be able to ensure that we have the high levels, management that can coordinate all sectors, we'll be able to provide some of the resources to be able to meet some of the gap that is currently available. But compared to what we have before, I think we are not where we're supposed to be, but we are not where we are yesterday. So we have been able to move a distance.
All right. Thank you, Dr. Benga. Now, Dr. Saleh, I'm asking again, how much of Nigeria's readiness, the much talked about readiness, is dependent on international support, and how much is locally driven?
So, as has been rightly mentioned, preparedness is not for one entity alone. It's an ongoing thing, it's not one-off. The state authorities, the international partners, the communities, the media, all of us have a stake in preparedness. We just had recently, there's a press release recently on the commitments of the government on setting up Ebola. Yeah, a kind of, because
not actual.
We feel it's commitment, it's actual, because you could see the setting up of a task force on Ebola preparedness with some budget provision there. So I think these are part of the commitment from the government. But from all of us as Nigerians, at this point, we emphasize that there is no Ebola in this country currently. There is no cause for us to be panicking. But we should be very vigilant, be well informed, because the idea is there is no area, nowhere where entirely is risk-free. But our surveillance and other preparedness systems are very active, I can tell you.
Yeah, but that's why I'm asking, how much of this preparedness, this readiness, is dependent on international support?
as I said, it's all of the society, all of the government, all of us doing these things. We can't, you've heard when WHO declared it as a public health of emergency concern, international concern. And the Africa CDC said, it's a public health emergency of continental security. So that means no one nation can do it alone. The government is doing their own. The state authorities are doing their own. Ours, we are doing our own in our own sphere of control. So the commitment is there, I mean, from all across. That's what I can tell you. For now, because preparedness is not something that you do one-off. It's an ongoing thing. And international partners too, and, corporate entities also have a stake in the public health.
Okay, Dr. Saleh, there was one major challenge that we had in 2014, and that has to be tracing, tracing, infected, people, I mean, health workers or even the people that are affected. So contact tracing was key in 2014. How has Nigeria digital surveillance and case investigation capacity changed since then when it comes to tracing?
Yeah, so you had alluded to the fact that the contact tracing was spectacular in helping us as a country containing Ebola.
Yeah.
There was a very robust contact tracing that really helped contain that Ebola. So we had even gone beyond that. For this current outbreak, that, as I said, preparedness is an ongoing thing. We keep learning and incorporating what we've learned to improve what we do. There is a contact tracing standard operating procedure now that we have in a place so that it guides a very objective and structured way of doing things. We had also, even the self-quarantine of those passengers of interest, there is a guide now that will do it so that we don't just do things haphazardly. We do it in a very structured way so that intervention can be so standardized and we do it as expected of us. So we're still, saying active case searches, contact tracing is very key activity for surveillance in really, really tracking those passengers of interest. It's usually done in 21 days where you will even have this self-kit for them, where you have the usual IPC supplies, like a toolkit. You have the face masks, you have the small consumable for them to use, the hand gloves, the thermometer, even the form as they are being followed up. If the part of the self-care, check that temperature and record in the form we give, and the state continue to follow them with calls and giving appropriate guidance so that it helps with the self-care as we follow them. Yeah.
Okay, thank you so much. Prof, you in
some messages?
Okay, let me just take this one there. We'll now take some messages, because I could recall that you helped build up the NCDC then. And what institutional lesson from 2024 and COVID-19 are most critical for Ebola today?
The fact that you have, a public health institute or a public health agency that is ready to go, a little bit liberated from the cumbersome, autocratic, mechanisms that when the outbreak comes, you go to PAMSEC, you go to director, you go to minister, all this. So establishing a national public health center as the NCDC was a huge achievement, and that helped Nigeria a lot to shorten our response time to outbreaks. I'm happy you are asking, Benga, how long will it take to respond if there's an outbreak? And with the existence of NCDC, the DG NCDC can immediately take action within 1 hour, 24 hours to respond to any emergency health, public health emergency, and so on and so forth. Then secondly, the lesson learned is that, maybe he didn't talk about, but he's going to emphasize on it later. We now have, sophisticated world-class laboratories, both in Lagos and Abuja. You know, we have BSL-3 laboratories, even though it was built with the help of Japanese JICA. It's one of the most sophisticated laboratories on the continent. And that laboratory has the capacity to do a lot and to identify any virus, you know, am I right, Gwenga, within a short period of time. But we shall come to the how do they, can they do it. Then thirdly, we have used the institute, the National Public Health Institute, to train so many Nigerians. We have this program we call Field Epidemiological and Laboratory Training Program. It's one of the most effective programs, again, on the continent. And we have used it to multiply the number of Nigerian public health experts. There are some states, when we started that program, that didn't even have a public health expert before, like Zamfara. But by now, I think, you know, they have up to 100 experts. Nigeria now is among the leading per capita of public health experts per healthcare workers. Then lastly is the issue of, you know, building up our raw materials. There's what we call the biobanks, you know. So where you store, let's say now the outbreak of 2014, we still have the pathogen, the virus that caused it. We still have it stored in NCDC. And we don't need to send our materials all out anymore. We keep our materials in case of any development. We can use it for vaccine manufacturing, for drug therapy manufacturing. We can use them for diagnostics. So you could see that from 2014 to now, we've learned a lot. We've established, I mean, the NCDC has showcased the importance of National Public Health Institute. And I'm happy to announce that, you know, on the basis of the success of the NCDC of Nigeria to have the NCDC, the West African Heads of State, ECOWAS, came together to say ECOWAS also needs its own CDC. And we helped them to establish it. Following that, African Union also said, no, we need a regional and continental center for disease control. So this is the birth of all this. So African Union now, we now have Africa CDC, which is playing a key role in enhancing our capacity to detect, you know, respond, prepare and respond effectively. Not just respond anyhow, but effectively. So these are the few things that between 2014 to now that we've been able to achieve. And, you know, as we are growing, so also we are carrying all other African, you know, states that need our support as the giant of the continent. They are looking up to us.
Thank you, sir.
All right. Let's take some messages from our viewers. And I begin with this one from Muhammad Awal Musa Fama in Kanu. He writes, given that Nigeria's readiness level is currently estimated at 59%, I repeat 59%, how will the 10 billion naira emergency fund directly support local grassroots risk communication to counter misinformation in rural dialects? Our community health centers and primary health care facilities across our local government areas properly equipped with the necessary personal protective equipment and functional isolation spaces if a suspected case appears? Well, he greets us all and says, may Allah bless us all. I think the second one from Prince Adelusi Olusegun from Jos. Good morning and thank you for this relevant topic. My advice is for the relevant agencies to please ensure thorough checks on travelers coming into Nigeria at the points of entry. I pray God will protect and shield us in Jesus' name. So, I don't know if you'd like to respond.
Let me just add this because of time. This one is from Alaji Garko from Karu site in Abuja. And he said, good morning, Nigeria. Good morning, presenters and the guest. The Nigeria's response to current Ebola threat by the federal government and the release of 10 billion naira by President Bola Tinubu is a welcome development. The response is a good move at the right time when Democratic Republic of Congo is currently battling with Ebola outbreak. I hope and pray that the resources released by the president will be used judiciously to prevent and detect any outbreak, as prevention is better than cure. Okay, Victor, go ahead.
Someone puts preparedness at 59%. I'm not sure you agree with that.
Yeah, so I would like to answer the second question. Dr. Benga heads preparedness because at each time we do readiness and as things evolve, so he may have the latest figure, just for the context. But for the one regarding the passengers of interest, I had mentioned here that we had a very robust contact tracing protocols and how these passengers of interest are being followed up. Nationally, we have the digital surveillance platform where these are entered. As they land, the QR code thing they do with the plugin. Yeah. We have such a database, and such informations are being analyzed on a daily basis, and we disaggregate by states and send such information to state, because the following up and the close monitoring of these passengers as they come in are actually the purview of the states, because these people move to such states as they come into Nigeria. For instance, the ones that are for Lagos, we give them the data and they continue to follow them, those passengers of interest from such countries of interest. So that's what we do. Yesterday, we were able to also share the latest ones we have. And I tell you, and that was how we were able to track that suspected case that we said that came from one that was domiciled in one state, and it's been discarded because we did all the due thing that we are supposed to do. Test result was negative, but close monitoring and follow up of that till the 21 days is still continuing.
All right, Dr. Benga.
Okay.
The other question talks about the percentage, level of preparedness, puts it at 59%. Is that the case?
Yes, that is the actual score we had when we did use our readiness checklist about some few weeks ago.
59.
So, what is the readiness checklist actually help us to achieve? It's not the score that actually matters. We have different pillars, and those pillars there are different questions that we ask to check our level of readiness, that if you have a case now, we can respond effectively. So we do that across different pillars, from surveillance to laboratories, workforce, the IPCs. And be able to tick something and give them like a weighted score. Now that has helped us be able to do plans, and we plan it. So as a name comes in, we also ask them to put the diseases factories and act. We had the these 5 optimus here for take not the progress and the main name of the truck help every that under sequence we have all the extra that we contain them to be to take that is effective. But the level of things are therefore public emergency centers. So all stakeholders come together based on unified objective to achieve common purpose. Primary health care will come and support the use of vaccinations. NCDC will come to support surveillance, support laboratory testing. Animal health will come to be able to support the surveillance within the animal health sector. Ministry of Communication will come to be able to support community engagement and all of that. So that structures has been put in place, both at the national and at the state level. And that's enhanced, unified coordinations at all levels to enhance how we respond effectively.
Okay, now that you have mentioned the Ministry of Information now, because I know that public awareness is very critical, especially in preventing panic and misinformation, which we had that hurt the 2014, Ebola case. We had a lot of misinformation, disinformation, and malinformation, which we need to manage at this point in time. So, what's the communication strategy that the government is putting in place now, to build trust without causing panic, within the populace? NCDC has tried to be able to identify one of the strengths to ensure that there is a community trust in this response. And we have different approach that we use to ensure that we engage the communities and inform the communities on what we are doing transparently, open up and tell them what we are doing and the current situations of things, and be able to provide them some of the measures they need to take so that they can actually prevent the possible, prevent the Ebolas within their own communities. We have what we call infodemic management, whereby we do a lot of analysis and see what is the reaction to different issues, identify those gaps at every point, and be able to provide solutions. Constantly, there is a risk analysis to ensure the gap in terms of communications across different stakeholders, and we put different measures in place to be able to reach out to them. One of the things at the national level is to provide constant advisory to the state government, constant advisory to the public, and then to the community levels. And we also engage the health promotion officers, both at the local government level, then at the state levels, to be able to change, appropriate, methods and communicate to the public so that they can be able to know what they need to do to prevent from the possible, outbreak of Ebola within their communities. All right, thank you very much. Prof, earlier on you talked about the issue of probably maybe talk of vaccines and therapeutics. What's Nigeria's access status right now, and who gets prioritized if doses are limited?
Okay, first and foremost is how do we even get the vaccines and the drugs? And in the past, virtually we rely on everything. I mean, on the foreign distance we import everything. So I think we should now grow above that stage, whereby we should include into our emergency preparedness and response strategies, plans to start, producing your own products. And doing so, I'm trying to say we should start emphasizing research and development. And so somebody mentioned, I think from Garuku or something, who said, the 10 billion naira given should be, judiciously used in such a way that, we strengthen our capacity, and at the same time, ensure that we can minimize dependency on, foreign whatever. So, for instance, this current outbreak of Ebola, the world panicked because there is no known therapy, no known cure, and no vaccine for it. So how do you, address those issues? So Nigeria, we have done so well, we said, with the Ebola, with the COVID, but everything we used during those outbreaks were all imported, were all things we relied on outside. We are a giant of Africa. The African countries are looking up to us. Time has come for us to start researching and looking into how do we develop our own products to fight this. For instance, during the 2014 outbreak, despite the fact that we are struggling to control that virus spread, we were also doing research. Our group, we developed what we call Ebotab. It's an antibody that could easily be used to treat, the Ebola. Even though it's a polyclonal antibody, it was not yet used, in this. But the clinical trial that were conducted in Sierra Leone and other places showed it's effective as compared to the monoclonal one that was, developed outside. So we did an R&D. We have a product. Now on this current outbreak, when the Bugio, they say no therapy, no drug, non-drug. We can't rely on only the foreign distance to be doing the research and get that drug for us. The virus is virtually indigenous to Africa. I think time has come for us to start looking into our universities, our research centers, to be providing answers and be developing these drugs. As I'm talking to you now, I'm chairman of a company called AMA Medical. We are partnering with an American, pharma. It's a small pharma, but to come up with a drug that can actually be used in treating the Ebola disease and minimize and reduce its impact, especially the case fatality rate. And some of the few trials we have conducted, shows that the combination therapy that we are trying to propose, which we are going to write to the president, that we have this product, so that the president will come and see how they can help Africa and Nigeria to really come up with indigenous solutions, not solutions that are brought for us from all these institutions. So that combination therapy is definitely very promising. We are partnering with a company called Trust, and we believe in the next few months, Nigeria can prepare. We can prepare Nigeria to have our own antibody therapy, to have our own drug therapy, to start showing and then take African countries along. For instance, I just came back from Geneva. We met with an agency called, African Medicines Agency, and we have been working very closely in all our clinical trials with NAFDAC. Here the African Medicine Agency is like NAFDAC for the whole African continent. They are welcoming these ideas that, look, let's start looking for our own molecules, our own substances, our own pathogens, to start developing those tools we need to fight all these outbreaks. So these outbreaks are indigenous. Then the African scientists must be empowered to provide local solutions.
All right, thank you very much, Prof. Okay, there's still one more comment here that's from Nandem Weir from Jos. He said, I think our poor attitude towards personal hygiene and environmental sanitation is one of the factors. When there is an outbreak, we become sleepless, restless, and start running helter-skelter, trying to put things in order using the fire brigade approach. But the moment we assume the storm is over, we then relax and become lenient and very friendly with the rats, cockroaches, and bush meat, mosquitoes, and others. Carrier of deadly virus once again. It is a wake-up call to be sensitive to our environment, personal hygiene, and strict avoid contact with hazardous materials. God bless Nigeria. Victor?
Yeah, I have one more too. And this is from Sam Kakaki in Kaduna. He says, kudos to the government and the response team. There's still lacuna in information and awareness, especially at community levels where superstition holds sway and not enough labs. Please step up in that area. Perhaps this is an advice, but it's an area you may want to also talk about, Dr. Saleh.
Yeah, I agree with you. One of the key gaps, even for some of these affected countries, is community mistrust. Community mistrust is a driver of so many things. We saw on social media how even the burial, activities for a disease had really, it's a recipe for really spreading the virus. So it's very important to have this community trust. And it's one of the key things that really helped us contain Ebola. Aside the robust contact tracing, I can tell you that community cooperation then, especially in Lagos, because people are cooperating to provide information, to do the needful. So we cannot but ensure that we build community trust by what we are doing in terms of, we call it risk communication and community engagement. You could see even the communication teams, what they do sometimes, even for their information they pass to communities. They do that by getting some even information around perception. They do what they call perception surveys. That will inform how they because they have a hint of what's going on around the community, what the feelings are, what the concerns are. So that will now inform even how they frame such information products to those targeted. The communication teams, I think they are doing that.
All right,
and you can also agree, okay, the media engagement that we do around public health events with you guys is also part of ensuring that you also help in creating rights information to the community. So,
all right,
yeah,
thank you, Dr. Saleh. Yeah. But in 30 seconds, Prof, tell us about the coordination effort.
Coordination efforts usually to be effective should start from the president, our head of state of the nation. And I want to say, during the 2024 outbreak, you all remember the role of 2014 outbreak. You all remember the role of President Goodluck Jonathan. He virtually led that fight. And then the two ministers, Christian Chukwu, and then Labaran Maku, of information. So information role was so important. Then at the state level, remember Fashola in Lagos, he took charge, and Governor Fashola, and then in Rivers, Amici was all on top. So it starts from that executive power to go down. Command structure, very, very important. You know, then comes to the levels of ministers and then institutions. Then, when it comes to what they call is Ministry of Science and Technology, Ministry of Foreign Affairs, National Orientation Agencies, all, operating under that command structure, always makes the response more and more effective. Thank you.
Thank you very much, Prof. I believe that our leaders are listening to this conversation this morning, and they will do the right thing. Professor Abdusalam Nasidi is a virologist and pioneer DG NCDC. Thank you so much for your contribution this morning.
Thank you.
Also, we want to thank Dr. Gbenga Joseph, Deputy Director and Head of Department, Health, Emergency Preparedness and Response. Dr. Joseph, thank you so much for providing information this morning.
Thank you.
And last but not the least, Dr. Fatima Saleh, Director Surveillance and Lead for the Emerging Viral Hemorrhagic Diseases. Thank you so much for your contribution.
My pleasure.
All right.